So hello everybody. So I welcome you to a symposium, a medical symposium from Telix. And actually we talk about size matters, but it's about radioligand therapy, I can assure you that. My name is Victor Grünwald. I'm a medical oncologist from Essen, Germany. Not far from here, to be honest, so about 4 hours of travel. It's a great privilege for me to speak to you today and share this session with such a privileged and great faculty, actually. And about myself, it's something, you probably have to know, I'm from Essen, so you probably know that we have a famous nuclear medicine person, which is Ken Herman, and we do closely work together, and we actually started an institute on the topic of GU cancers across urology, medical oncology, and nuclear medicine. And I think for us, it's a great way forward to develop the field, to be honest. So with no further ado, I would like to give you some overview on why we do this lecture, this symposium. And first of all, there are disclaimers, and of course, we will speak about non-licensed agents that are licensed in some parts of the world, which is the North Americas actually, but not in Europe. And also some of the products are really investigational. I think that's something that is clear, and then there are some conflicts of interest of me. So what is nuclear medicine really bringing to the field of oncology? And I think having nuclear or molecular imaging is really a great opportunity in the field of cancer, because we have already many of different possibilities to assess the cancer. It's genomics, but most of the times it's at a very singular time point where we do this assessment. So looking for mutations, for instance, you do that prior to your choice of therapy, and if there's a mutation that is druggable or targeted, we just succeed with that therapy. So, and I think with the modern imaging techniques that we have now, we can image molecular changes or epitopes in cancers. And I think one of the major advances is you can do this repeatedly throughout the course of treatment. And that probably will give you much more information about the disease during the course of treatment. I think that's a great opportunity. And then speaking of, what are different targets? I think, they can be very different. It could be, you could target the immune system. You could, image the tumor itself or the tumor microenvironment. And I think these are really great opportunities really for novel diagnostics in the field of oncology, actually. And this is an image that shows you how exciting the field is really developing. And for me, because I'm med-onc, we had this moment actually, I would say 15 years ago. It really reminds me of the time when checkpoint inhibitors came to the field of oncology and really transformed how we treat cancer patients today. And I think I see the same excitement really happening here, and lots of pharmaceutical companies really investing in this novel technique and novel opportunity. And I think that's, it really is a field in motion, and that's great actually. So when speaking about the different modalities, and again, I'm med-onc, so with the exchange of our nuclear medicine guys and persons, I really learned a lot about different tracers and how they can be used, and that's also the topic that we have really today. It ranges from monoclonal antibodies up to really nanoparticles, and what is the difference between a small molecule, between the peptide, between a monoclonal antibody, and where is it used best? And I think really in order to optimize therapies, to a different disease or a specific disease, you really have to understand what is the tracer system, the carrier system really capable of doing and performing, and it's about pharmacology at the end and the biological applicability. My perspective as a GU oncologist, so I always use GU cases, and I think, looking into the field of prostate cancer, we had really exciting times in the past years with the radioligand therapies coming to the clinics. And speaking of PSMA targeting agents, I think there are different ones that are also in clinical development, and here you see two different principles. One is a monoclonal antibody, the other one is a small molecule, and there are differences in the way how we image, and there are differences how the excretion is being performed. Either it's renal or it is hepatic, and also in regard to the off-target bindings, so about specificity, the affinity of the target or the tracer to the target, and that kind of determines, of course, where we do see toxicities and how those agents really behave in the clinic. So it's important to understand. And then the next topic, and that will be also addressed during the speeches here, is really what about CA9? I mean, CA9 is a marker that comes with hypoxia. And the special case in kidney cancer is really it's constitutively active because of the molecular changes that we have in clear cell kidney cancer. And therefore, you will have a very high CA9 expression level on every single clear cell cell. And that is what makes it really a good role model to develop a tracer that is really targeting CA9. But there are differences. I mean, you can use a monoclonal antibody, which is girentuximab, radio-labeled, and then there is also a small molecule or peptide that can be used. And again, look at the different distribution, look at the GI imaging that you see here. So there are differences in how those drugs behave or agents behave, and that probably will also play a role in the clinic. It could be a hurdle or a barrier towards its therapeutic application. So with that, I would really like to thank you for your attention, and this is our great faculty that you will see in a minute, one by one. They will appear, and then we'll speak about different topics. And we started really off with Arturo, and Arturo Chiti is a professor from Bologna, and he will speak about really why size matters. And he's also the past president of EANM, and he's also the chief editor of the European Nuclear Medicine Journal. So I'll give him a round of applause when he comes to the podium. Thank you.
So good morning, everybody, and thank you very much for being here. And I want to thank Telix for inviting me. Actually, I was born in Bologna, but I'm working in Milan, so no worries. Today my task is to pave the way for the next speakers and try to introduce you to the let's say, topic of the relevant fields regarding the size of the molecules that we are using for targeting the tumors that we are treating in these cases. So most of us were trained focusing on the radionuclides, and this is unfortunately still the reality. So most of the nuclear medicine physicians, we are focusing on, are we using actinium, are you using lutetium, are you using technetium, are you using whatever radionuclides. But the real core of what we are using is in the molecule that we can label, or at least our radiochemistry or industry can label. So I will try to make a very short story on what is behind these different molecules. So you know that we have these, let's say, big molecules, the antibodies, and ages ago when I was young, we had this idea of the magic bullets, and we were using just full antibodies. But at that time, the technology was not there. We were, in the end, not able to bring this really into the clinics. We made a lot of patients, a lot of clinical trials, but most of them, they were unsuccessful. But nowadays, we have the technology to prepare very good and selective antibodies, and then we can go down to the fragments of antibodies and the, let's say, small molecules. We made this distinction between small molecules and peptides, but I would not say that a peptide is a big molecule. Anyhow, we have, let's say, all this range of different moieties that we can use. So, as I already mentioned, the vector is crucial for the effectiveness of the therapy, because what we are doing is that we are trying to target something which is on the cancer cell, and we need to have the good vector. So we have antibodies, peptides, nucleic small molecules, and so on. So of course, the specificity is the most important thing, but there are multiple factors. Of course, the technology that we have to use to produce and modify the molecule, we need to have really very high specificity and also selectivity. And we need to have a very high concentration on the target. Then we also have the issue of the immunogenicity, although, you know, in between there might be some synergic effect with some molecules. So there are many studies ongoing, but you know, so far we will concentrate on antibodies, peptides, and small molecules because we have at least some data. So antibodies. There are examples of treatment with antibodies. You know, these are radiopharmaceutical that has been approved, like the ibritumumab, and this ibritumumab was approved also in Europe, and the tositumumab was just approved in the US. But they were used for targeting the CD20 in non-Hodgkin lymphoma. This was quite a successful therapy, but then for several reasons that I'm going to discuss today, it never flied. Then there were some examples for targeting CEA for the treatment, of course, of colorectal cancer. Again, this was definitely less successful, so we don't have really a clinical value yet for this. There are also, let's say, fragment of antibodies, like this one that is single domain antibody targeting the CA9. You see here, and this is something that you have to keep in mind always when you are using different molecules, that there is very nice possibility to look at targets outside the kidneys, but of course then if you want to look at the kidneys, you see by yourself that it's going to be quite difficult to distinguish between the tumor and the normal background. So it's like using FDG to detect brain tumors. And this is an example of an antibodies which is not yet approved, but hopefully it will be approved very soon. And you see here how the contrast resolution is high. You see here there is the primary lesion, and here you see a metastatic lesion. Of course, the side effect here, let's say, the not ideal logistic is that you need to acquire images after some days after the injection. But at the very moment, I think that it is really worth waiting the time, because you look at the images and you realize by yourself that the images are very good. Then, if you want, you can also do something more that we have done in our centers, thanks to our physicists and to our preclinical researchers. And you see here that there is really a perfect matching between the specimen, the ex vivo micro-PET CT imaging, and the staining. So the long-lived antibodies could have also potential application with ex vivo imaging. So going to peptides. Peptides, they are nowadays very fancy. This is one example, again, of a peptide against the CA9 epitope. And you see here very nice images for the distant metastasis, but for the abdomen, it might be very tricky to have interesting results. Of course, there are many treatments that has been proposed also for peptides. You know, some of these peptides are the GRPR agonists or antagonists. There are many different radiopharmaceutical proposed. There are some clinical trials using lutetium-labeled peptides like the AMBA, and most of them, they are focused on prostate cancer. We'll see if they will be successful in the future. Small molecules are those that we are using in many centers almost every day. Here you see an example of a PET-MR with the gallium-68 PSMA-11. You see here the primary tumor and a tiny lymph node clearly depicted in the pelvic area. Peptides like PSMA has been also proposed in order to assess renal cancer. And this is an example of a patient that we studied with a remnant in the kidney bed. You see here very faint uptake and a lot of uptake in the kidney. So yes, you can do, but it's definitely suboptimal. And you see also here with another peptide, here is fluorine-18 labeled PSMA 1007. You see this is something that might happen in the clinical practice. You're studying a patient for a prostate cancer and then you end up seeing also a tumor in the kidney. You see again the added value here compared to the contrast enhanced is questionable, but again, if you compare with the what you can get with the full antibody, so it's completely different kind of imaging. We have, of course, clear, nice examples of treatment with small molecules. Of course, the lutetium PSMA 617 is the one that is more used and discussed also during this Congress. And you see that there are other small molecules, because you know small molecules are a family of molecules. Sorry, and we are using these small molecules with different radiopharmaceutical, with different radionuclides and very similar molecules. But we are also using that in combination therapy, and then it will be to the to us and in collaboration with the oncologists for the combination therapy to see what will happen in therapy. This is an example of treatment on a patient that we acquired in a small study that was done in Italy, and of course the examples are really astonishing when this therapy works. And this is another example of a small molecule that again is targeting the CD70, and you see here very nice images for the possible distal metastases, let's say for the M staging, but for the small molecules you have still this problem that most of the time you have a very high uptake in the kidneys or in the on the colon or the intestine that might hamper the evaluation of tumors coming from the abdomen. So going to the end of my talk, you see, just to summarize, we have big molecules and small molecules, like really small molecules or peptides. And of course, the main difference is in the kilodaltons. You see, we are going to 1 to 3 kilodalton to 150. Affinity for antibodies is generally higher in the level of pico or nanomolar. Stability is higher also for antibodies. This is why also we can label them with long-lived radionuclides, like zirconium or iodine-131. And the blood clearance is lower because they are big molecules. And of course, when you're using peptides or small molecules, the clearance is definitely faster, which is an advantage, but it has to be balanced. The target accumulation is slower for antibodies, very fast for peptides and small molecules. This is why we are using different radionuclides. For peptides, you can use short-lived radionuclides like gallium-68 or fluorine-18, something that we can't do with full antibodies. Tissue penetration, of course, it's deeper with small molecules, it's intuitive and faster. For antibodies, again, is lower. Internalization is more difficult for or impossible for antibodies, and the possible immunogenicity, of course, is higher when you are using full antibodies. So the take-home message, okay, this is a mantra of this conference. Okay, we have great promise from radiopharmaceutical for both diagnosis and therapy. And of course, we have to keep in mind that radiopharmaceutical is not a radionuclide, so it's a more complex molecule. And at the moment, we have very good radiopharmaceuticals in terms of diagnostic possibility or therapeutic possibility in both domains. You see, we already have delved into the differences between small molecules, peptides, and antibodies, but the choice has to be taken in consideration of the tumor that you want to target. So treating a tumor is not just realizing a molecule which is carrying a radiopharmaceutical. It's a more complex phenomenon, and we don't have to forget that realizing such molecules is quite difficult, but so far we have available a lot of technological improvements that are nowadays under our eyes, because you see how many new radiopharmaceuticals are really keeping our field in the very high level with a very high interest from everyone. So thank you very much for your attention.
We come to the second talk, which is then now from Stefano Fanti, who is a professor for the Division of Nuclear Medicine. So this time it is really Bologna, I think, I hope. And he's also he has a strong research focus on prostate cancer, but also on hematological malignancies. And I think that's something that will be also touched in his topic. So Stefano, the floor is yours.
Thank you very much. It's my pleasure to be here, and thanks for the invitation to the Telix people. Yes, correct. I'm from Bologna. So when we were at the kindergarten with Arturo, we realized that the town was not large enough for the two of us. And, you know, the history is that he moved to Milan, and I stayed there with the pro and the cons. These are my disclosure. I have a serious disclosure, which is a confession indeed. After some 10 years, I'm getting bored of prostate and PSMA. Because, you know, life has to change, so I did my best with total body PET and other topics. And Fred came to me and he said, why don't you want to talk about something new? And I said, yeah, I would be happy, but I don't know what about. And he reminded me, oh, but you were very active in the treatment of lymphoma with an antibody. I said, well, 20 years ago, I don't have a clue about what I was doing at that time. So now the challenge is to talk about something that indeed I covered about 20 years ago. Imagine, that's so sorry about that. You know, it's probably the first time out of my area of comfort with the prostatic things. But I said, you know, prostate is getting a bit boring. It's really overcrowded. You know, everybody's doing prostates right now. Okay, so let's talk about the targeting of hematological cancer. Hematological, no prostate. There is this advantage, it's very well known. There is a lot of antibodies which are overexpressed on the surface. So you can easily target them. This is absolutely well known. You can target directly with the monoclonal antibodies, and Arturo already told us which was the emphasis in the late 90s about that. It was probably too optimistic. We have seen that it doesn't really succeed as much as we were hoping. And then it was antibody drug conjugated that came on stage. That is to say, the target is there, but let's make something smarter than those big, big bullets. And of course, the next point is, okay, let's put radioactivity there. Let's have the radioactive ADCs, and let's see if they are going to work. So essentially, we'll try to cover those aspects. And well, ADC really had an impact. So it was very successful, starting about 20 years ago, I would say. And of course, we are talking on hematological cancer, but also other cancer. So there's more than 100 of those products already in the clinics. So a big success to every extent. It worked. It worked because, as I said, you know, the limitation of those big molecules have been somewhat overcome by using some conjugates, so adding the value of the target plus the factors. And here we are to Zevalin. That, as Fred reminded me, was one of my, long ago weapon that we used for the treatment of lymphoma. It was non-Hodgkin lymphoma. And the concept was very simple. I mean, there was trials, very well done, demonstrating that the overexpressed antigen could be targeted and treated effectively with yttrium. That was a very simple principle. However, as said, it has a little time of success, but thereafter there were some problems, logistical problems, because at that time there was not a lot of theranostic center. There was competitors, so alternative therapy that were not implying radioactive, and of course radioactive is not an added value, but it's a practical limitation. And there was some concern regarding the HAMA, so the induced antibodies. And that means that Zevalin has been a little bit abandoned, if not completely. Now the issue is we now have new radioactive ADC. Will they skyrocket just like the non-radioactive one? We will have something like a resurrection of the Zevalin-like treatments. Well, the concept is very simple. There is a collection of targets, of antibody. You can, okay, the arrow is not there. I can point the arrow. You can have to trust me. It's CD20, CD38, CD37. So a number, really. There is a lot of targets you may try to hit. And you can do that with a theranostic approach. So, of course, you can image and you can treat. It's just a matter of adding the correct isotope. And Arturo has already completely covered the issue of the size. So the larger would mean longer stay in circulation, impossibility to enter, or very difficult capability to enter. But that could even be an advantage if you're thinking not a solid tumor, but hematological disease, which is not related to a lump, to a mass. You don't have to enter. You have to stay in the blood, essentially. That's the very simple principle. And, of course, there is issue regarding the non-specific uptake. You don't want to target the spleen. You don't want to target the liver, and so on. But this is something that, of course, could be somewhat overcome. And here we come with the very obvious idea. I mean, it's impossible to have one best size and that's all. There may be advantage for a large size and advantage for a small size, depending on the indication, depending on your molecule, depending on your isotope. So a couple of examples. Examples for monoclonal antibodies, so the big one, and peptides and nanobodies, so the smaller, not the super small, but smaller. And here we are, a couple of examples in the area of hematological, but let's start with something which is here, which is a nice example of using a smaller, like the pentixafor, so the targeting the 6CR4, which is very well known. This is a clear example of a small molecule approach. It's expressed in a number of malignancies. So essentially, it's been around since a long time, at least a decade, probably even more. I remember Professor Wester coming to Bologna like 15 years ago, teaching us about that. It's been a very smart approach, searching for an indication, essentially, to be very honest. And now, finally, possibly targeting hematological disease with this potential, again, of being completely theranostic. So you can image and you can treat. The advantage is clear. It's overexpressed in some form of hematological malignancy, so in particular multiple myeloma and some non-Hodgkin lymphoma, the marginal zone in particular, which is very refractory to therapies. And you can have the therapeutical counterpart, and these are examples of this. So, you can image the effect, but you can image the patient, and you can treat the patient with pentixafor labeled either with gallium and lutetium. So that's a possible successful concept for a relatively small molecule. But now let's move to the big one, okay? And with a different approach, and I was very happy when I start getting into this area, because we are very actively collaborating with the hematological department. And one major issue is stem cell transplantation, in particular induction of stem cell transplantation, which is a need. Of course, it's not first-line approach. It's in patients that have already been relapsed, difficult patient to treat. The concept is very simple. You have to clear the bone marrow of the patient. And to do that, you have different alternatives, and you have a very difficult balance to keep, because you want to clean as much as possible the whole bone marrow, but you don't have to kill the patient. So it's absolutely difficult to keep it. And there are different strategies, but one strategy could be using a radioactive ADC approach. And that's essentially what I'm going to talk. So the concept is a very thin balance that you have to keep in a very frail patient, because that's the other issue. Because this is a patient with a relapse. It's frequently could be, leukemia relapse, or some lymphoma, or some myeloma, which have been relapsing several times. So a frail patient in which you have to treat very hard, hit very hard, all the cells in the bone marrow, but at the same time keep the patient in a condition after induction that he can receive the transplant itself and positively react to that. So that's sort of an old concept, already developed and tried, but at the same time never really gained any clinical, practical implementation because of many difficulties, because of the lack of a good product. So we're going to talk briefly about two possible targets, which is CD45 and CD66. So essentially, you need an antigen which is overexpressed in the most type of cells that you can hit into the bone marrow. So this is the SERRA trial. I have to say, among the many products that we are all listening about, from FAPI to CXCR4 to many others, this is a little bit niche. So there's not much emphasis. But this trial has been done essentially in the US. It's a phase 3 trial. It's been published, successful, so it's randomized. And it was the commercial name is IOMAB, that was used for induction of the bone marrow before the transplantation, as compared to conventional, and it was successful. The trial published. The limitation is related to the isotope, is iodine-131. And everybody knows it's not a super friendly isotope for us. So, demonstrating superiority as compared to the conventional strategy to obtain the ablation of the bone marrow. The remission was more frequent and more long, so higher durable remission as compared to standard care, but some limitation related to the iodine-131. We can further discuss about that. So the concept is to change the target and to change the isotope. So in this case, it's CD66, and the isotope is yttrium-90, which is, of course, better by any kind of manipulation, dosimetry, and other issue. And the objective remains the same, so trying to have a good trial demonstrating the superiority with a conventional strategy for obtaining the bone marrow ablation. And this is the whole concept. And again, you have a theranostic companion that in this case is an imaging companion labeled with indium-111. Now, everybody knows that indium is not a fantastic image partner, but you don't need to make diagnosis in those patients. You just need to be sure that there is no area of uptake that can ruin your project of ablation of the bone marrow. And so it's a very preliminary trial, but I'm happy to share with you some data that have been provided to me. And essentially, the first 30 patients, they were a mixed up of hematological malignancy with myeloma, acute myeloid leukemia, or lymphoma, and they all received the transplantation. They all engrafted, so preliminary results are very good, and it was obtained that the transplantation was successful, but of course, it's very preliminary data, very small population, follow-up should be required, but it's a proof of concept, very interesting for a really innovative approach of nuclear medicine theranostic. The results are encouraging, so of course we need further studies, we need long-term follow-up, we need randomized study in a large population to get in some concept of registration. But in my view, it's a very interesting area, and it's of course very different from what we have been talking and hearing so far. So in conclusion, monoclonal antibody could be crucial in hematological malignancy, because of this advantage, which is intrinsical. That's to say, it's a liquid, liquid, it's a little bit excessive, but it's not a solid malignancy. So you can get advantage of some of what is seen or perceived as a limitation of the tracer so far. There is a number of targets. So I've been covering a few, but essentially there are really a number of antigens which are overexpressed, so we can probably play around that. It's a pharmacokinetics paradoxically favorable for the long circulation of our products, and it may represent an option for several patients, and again, it could be just the beginning because the stem cell transplantation is still a very effective therapy, though very complex, very difficult and expensive, so it's better to achieve the higher rate of success of this. And of course, radio treatment could really be the new frontier in this area. Survived. I'm very happy. Thank you.
Yeah, and we do move on, and we do have Karolien Goffin from who is professor for nuclear medicine at the University of Leuven. And she leads the nuclear medicine clinic and research program. And I think, from when I studied your vita and what I've seen, you have interest in GU cancers and head and neck cancers. I think that's great because I think that's something that I've done in the past as well. So it's wonderful to have you here. And please, succeed with your talk on how the science will really shape the future.
Okay, thank you for the kind introduction, also for the invitation to the Telix team to be present here today and indeed talk to you about uro-oncology. I usually agree with Stefano, but in this time I must disagree. I think prostate cancer is still quite attractive, quite challenging, and I hope that I can convince you with some new data and some new trials that are upcoming and that may again give a change in the way that we approach our patients with prostate cancer. These are my disclosures. So we'll start with prostate cancer. We've heard this morning in plenary 2, also in one of the CME sessions, about the VISION trial. So you may think we have PSMA 617, it's reimbursed, we have overall survival data, we have progression-free survival data. Why do we need anything else for the treatment of patients with prostate cancer? And I agree, the VISION trial shows great data, and this is a trial that is a drug that's very active and that really has a great benefit to our patients, but there are maybe things that we can still improve on. And although patients do not suffer from severe side effects when they're receiving the lutetium PSMA treatment, there are still improvements possible. We know that patients can have xerostomia, they can have suffer from dry eyes. There's also some patients that are not doing well under the treatment, where we have to discontinue, often after 2 cycles. If patients can get to the second cycle, they're more likely to complete the entire treatment scheme. And if you look at reasons why patients discontinue, this is mainly due to 2 main reasons. One is hematologic issues, mainly low platelets. And then a second cause is that in some patients who have very aggressive disease with fast progression, although we're giving them a very active treatment, they still progress during the treatment, and then we need to discontinue based on a rise in PSA, for example. So we still can do better, and what was also becoming more clear when we're moving our lutetium PSMA treatments more to the earlier stages of prostate cancer is that there may be a long-term nephrotoxicity signal that we didn't see in the initial trials when patients unfortunately did not have a very high overall survival after they received the lutetium PSMA treatment. What you can see from the graph on the left is that if patients have a longer survival time, that there is a gradual decrease of the GFR over time. There are some risk factors that are associated with this higher percentage decrease. These are mainly patient-based and are not based on the number of cycles that patients receive and also not on pre-treatment lines. So there is still room for improvement, and one of these approaches is an approach that we have seen come up with a monoclonal antibody. This is TLX591. This is a radio antibody drug conjugate that will target PSMA-expressing metastatic castration-resistant prostate cancer. We've heard from previous speakers about the advantage of monoclonal antibodies, given their high rate of internalization, also long potential and functional selectivity, in this case to the tumor-expressed PSMA. And so far there's data available of approximately 250 prostate cancer patients that have been treated with this compound in several phase 1 and phase 2 studies. And when taking the data from these studies together, we can see that regarding overall survival, the value is quite promising. So at the moment, and from these patients, the median overall survival is at more than 40 months, and these were patients that were heavily pre-treated. What's also interesting is that in contrast to lutetium PSMA treatment that we give in 6 cycles or 4 cycles with typically a 6-week interval, this treatment only needs to be given to the patient twice, so basically 1 cycle with only 14 days apart. What's also became apparent from the initial data that we have is that there's a low occurrence of off-target side effects while still delivering a meaningful therapeutic index that is then represented by the long overall survival time. So there are several areas where this approach with monoclonal antibodies can overcome some of the limitations of the small molecule approach, and these can be grouped in 3 categories. On the one hand, what I've already mentioned, we may have a longer overall survival. That's what we see from these early studies. Of course, we need to confirm it in larger trials. Also regarding patient quality of life, there may be advantages of using this kind of approach, as we have no renal toxicity, also no xerostomia, no dry eyes, and no problem with ganglia irritation. Also the patient profile or the follow-up that you need can be quite well based on the initial hematological profile. So regarding quality of life, this is also important for our patients. And then for us, on the one hand, as nuclear medicine physicians, or I should now call us nuclear oncologists, and also for the patients, of course, is the easy way of administering this treatment with only 2 doses and also lower cumulative radiation exposure. At 150 millicurie, more or less, where with a full lutetium PSMA 617 treatment, if you give 6 cycles, you're almost 10 times higher in activity. And this offers advantages for your service and, of course, also for your patients. Let's look at some more details about this compound. So why do we see this advantageous safety profile? What you see on the left is an indirect comparison between the uptake of TLX591 and the PSMA 617 in normal organs, where you can see that if you look at this indirect comparison, there's a lower total dose in many organs with TLX591 compared to the PSMA 617, and this then also is reflected in the lower adverse event rate. Also means that there's a low bone marrow dose and also a low dose to the liver. If we look at the uptake, you can very clearly see from the images on the left that with this compound we can have prolonged retention in target tumors. On the left, you see the baseline image, PET image of a patient with extensive, mainly bone disease on the PSMA PET scan. And then from 24 hours onwards, you can see the targeting, which becomes very intense and stays very intense until the final time point that we have here on the image. And I calculated this for you. This is a 13-day image. So even after almost 2 weeks, we still have excellent targeting of our tumoral lesions. If you compare the images on the left, which are the TLX images, compared to the images on the right, it's also clear that you can see why patients receiving TLX will not suffer from xerostomia or dry eyes. You can clearly see the difference in the physiological uptake of the compound compared to 617. So based on these preliminary data, we are moving to a next larger randomized trial. This is the ProstACT Global trial, where more than 500 patients will be included in 2 parts. In the second part, this will be a randomized trial where about 500 patients will be randomized in a 2-to-1 fashion between either receiving standard of care or standard of care plus the TLX compound, and the trial is powered to have to be positive regarding radiographic progression-free survival. Do we need to look any further, or should we stop just at PSMA? I think also this morning we heard great new ways in which we can expand, broaden the potential targets that we can have. We can think about FAP. This is mainly being discussed in other tumor types, but there's also some case reports and imaging series that it may be interesting in prostate cancer. And then you can see that also in regarding different targets, either antibody-based or peptide-based, there's quite some novel targets still on the horizon, and it's interesting to see where this will bring us in the coming decade. Moving from prostate cancer to renal cancer, and we've already seen some of the images and heard a little bit about the new, what we have possible for renal cancer imaging. So again, here, why should we move beyond PSMA? We can use PSMA for everything, so also for RCC. There are some limitations why you would not, or why PSMA imaging is not ideal for RCC imaging. For example, it's not possible to, or it's difficult to differentiate a clear cell RCC from, for example, an oncocytoma. There's also a limited role in differential diagnosis of indeterminate lesions. And if you want to investigate the primary tumor with many of the PSMA compounds that have an excretion through the renal system, we will have a low tumor to background ratio. And what is also of importance is that we see the neovascularization with PSMA rather than the RCC disease. That's why it is very interesting that we now have data available on CA9 for imaging in clear cell RCC. And this data comes from the ZIRCON trial that has been published this year. So CA9 is a target that is well validated and that is expressed in up to 95% of clear cell RCC tumors. And we can target it using girentuximab, which is a monoclonal antibody that has a high specific binding to CA9. There is extensive evidence on the safety of girentuximab. It is being excreted to the hepatobiliary system, which is interesting when you want to image the kidney. And it can be labeled either with zirconium for imaging or with lutetium for treatment. And we have seen these data already. So these are the positive results from the ZIRCON trial, just for your information. So this was a trial where approximately 300 patients were included that had a single indeterminate renal mass that was up until 7 centimeters in diameter, and that was suspicious for clear cell RCC. These patients then underwent a zirconium girentuximab PET-CT scan, and the data of the imaging was compared to data available from histology. So we have a very good gold standard in this trial, and the trial was positive for the both endpoints, being sensitivity and specificity. So the sensitivity was at 86% to detect clear cell RCC specifically, and the specificity was also very good at 87%. These values also hold true when you look at only small renal masses. These are masses with a diameter up until 4 centimeters. And although this was not part of the primary and secondary objectives, it's also interesting that in patients who received a total body PET scan, that you were also able to see extrarenal lesions, pointing towards the potential role of this imaging modality, not only for primary, for detection of lesions and differentiation of lesions, but maybe also for primary staging or imaging at further stages. The data also strongly validates the CA9 targets as potentially groundbreaking in clear cell RCC, as PSMA has been for prostate cancer, and it opens the door to using this target also for therapeutic options. This is again the paper. If you haven't read it yet, I strongly encourage you to go to the website of Lancet Oncology and have a look at the paper. It's really a great set of data. And just to show some of the images, here you have 3 patients with a single lesion in the kidney, clearly showing high uptake on the zirconium girentuximab PET-CT. You can also see the very high tumor to background rate. So this is of course also because we image only after a couple of days. So this is one of the, on the one hand, disadvantages, but also advantages of using this kind of an antibody approach. So what about therapy? Here we are slowly starting to move into the therapeutic space also for renal cancer with a couple of trials that are being run. On the left you see 2 investigator-initiated trials, phase 2 trials, looking at the combination of the TLX 250 therapeutic compound with different types of IO in patients with clear cell RCC. On the right, you also see a novel trial investigating not only RCC, but also other types of solid tumors, where again, a combination treatment is being tested. And just to conclude, I want to just mention one of the rationale, so one of the potential combination treatments that we can do in this case with immunotherapy. So on the one hand, we have the lutetium compound that will target specifically the tumor, will administer internal radiation while limiting the radiation therapy exposure. And on the other hand, the irradiation of the tumor cells can enhance their immunogenicity to potentially increase the response to the IO treatment. So these are all data that we're looking forward to see more, what these trials will offer us, if this will also open the arena for radionuclide therapy in RCC. And with this, I thank you for your attention.
We now move to our last speaker, which is Nathalie Albert. She is a professor at the Nuclear Medicine Department at the LMU, the University in Munich, and she leads the field of neuro-oncology, and that will be, where we do have a completely different compartment system, I would say, and therefore we do need probably different tracers. Is that the case?
You're here now. Thanks a lot for the introduction, and I'm thankful also for the opportunity to talk today about theranostic approaches in neuro-oncology. These are my disclosures. Well, we all know that radioligand therapy works extremely well in oncological diseases, and therefore it does not surprise at all that we read headlines like this one. Theranostics could be big business in precision oncology. And of course, I would be happy to make it also, to make use of it in neuro-oncology. Why? Well, in neuro-oncology, we have a very high clinical need for new treatment options because we're dealing with very aggressive tumors with very poor prognosis for the patients. And unfortunately, we always see publications like these ones showing that, that most of the treatments fail, and therefore we need new treatment options in neuro-oncology. However, in brain tumors, we're dealing with a special challenge. It's the blood-brain barrier. So what is the blood-brain barrier? Back then, Paul Ehrlich was the first person who described the blood-brain barrier. What he did is he injected a blue dye intravenously into guinea pigs, and he could see that all the organs turned blue except for the brain. So what happens here? I'm not going too much into detail, but the thing is that the endothelial cells of the blood vessels in the brain are connected with tight junctions, and then you have a very strong basement membrane which inhibits that just everything that is in the blood can move and transit to the brain. So it's intended to protect the brain, which is our most prestigious organ. But there are methods of transport, for example, carrier or transporter-mediated transcytosis, receptor-mediated transcytosis, and very small and mostly lipophilic molecules can also diffuse to the brain transcellularly. So what does that mean for theranostic approaches in neuro-oncology? Well, we should start with something that is small and that can cross the blood-brain barrier. So if we start here with small molecules, for example, with radiolabeled amino acids, we could be effective here. I'm going to focus now on the amino acids. And radiolabeled amino acids, which are also commonly used for PET imaging of gliomas in the brain, are transported via, across the blood-brain barrier through L-amino acid transporters, which are overexpressed at the endothelial cells of the blood vessels and also at the, on the brain tumor cells. So as I said, FET-PET, so FET is a radiolabeled amino acid, is usually used for brain tumor imaging, and you see a clear correlation with the tumor aggressiveness. And the good thing is that also the non-contrast enhancing parts of the tumor, so those parts where the blood-brain barrier is completely intact, can also be visualized. How can we make use of that for theranostic approaches? Well, there is IPA, and here I'm not talking about pale ale, which would also cross the blood-brain barrier, but about iodine-labeled phenylalanine, which is also an amino acid and can be transported across the blood-brain barrier accordingly. So IPA is already being used in patients with brain tumors in compassionate use programs and also in a clinical trial, which I'm going to show you later. And thank you very much to Nelleke, who's also sitting here in the audience from Utrecht, who gave me these nice examples of a patient with a glioblastoma, where you can see on the left side the contrast-enhancing tumor. Then you see the clear FET-PET signal, and after injection of the IPA, you see clearly that the tumor is really taking up the radiolabeled amino acid, and this patient, after 19 weeks of follow-up, was still stable, which you can see on the FET-PET. This is the trial which has just been published some weeks ago. So it's the IPEX-1 trial, the first phase 1/2 trial investigating IPA in patients with recurrent glioblastoma. And here 3 different treatment regimens were tested with regard to safety and tolerability of IPA. And the key results are that all dose regimens have been well tolerated. The organ-absorbed radiation doses in the bone marrow as well as in the kidneys were totally fine. And the total absorbed radiation doses of the tumor varied considerably, you have to say, between 0.75 gray and 13.26 gray. 6 of 9 patients remained stable at 3 months. However, I think there are lots of open questions because we still don't know which dose we should use in the future, what is the optimal treatment scheme, and with regard to the efficacy, we cannot really answer if IPA is working well or not. So regarding the dosing, another trial is currently following. So it's the IPEX-2 trial, a phase 1 trial now in newly diagnosed glioblastoma, and it is a dose escalation study in order to not only assess the safety, tolerability, and dose-limiting toxicity, but also the maximum tolerated dose in order to get a recommended phase 2 dose. And what I can say at this time is also that an IPEX-3 trial is already in preparation, which is foreseen to be opened next year, where hopefully we are going to go in a randomized setting. Okay, so small molecules like amino acids are of interest, but what about peptides in neuro-oncology? Peptides are considerably larger. Can we use them in neuro-oncology, or is it an absolute no-go? Well, we can look at our dotatate because SSTR, so somatostatin receptors, are highly expressed in patients with meningioma. So it's a prime radioligand therapy target, and we know already a lot about the tolerability and toxicity of lutetium dotatate, so this is certainly something of interest for meningioma patients. And SSTR PET imaging is also something that we very frequently do in patients with meningioma, because we see a very high uptake of SSTR PET tracers with a very good contrast, so you can really visualize nicely meningioma lesions and also recurrent meningioma lesions. And we have just recently published a joint guideline together with the EANM, IANO, RANO, and SNMMI. It's a practice guideline and procedure standards for diagnostics, but also therapeutic approaches with SSTR-targeted radioligands. But the big question is now, does lutetium dotatate therapy work in patients with meningiomas? And so far, we have to confess, we have to say, we don't know. If we look at the data that is available in the literature, most publications refer to retrospective data, single-center studies, and here you see the results of a meta-analysis showing that at least in 60% of the patients, you can achieve stable disease. And this is really already a success, because we're talking about progressive tumors. However, as this relates to retrospective data only, we have to state very clearly, and this is also what the authors concluded, that controlled studies are needed in order to really validate the efficacy of SSTR-targeted radioligand therapy. If we look at the current clinical trial landscape in meningioma, you will see that not only most of the studies, but that all studies are single-arm studies, so no control arm in all these studies. However, I would like to highlight one study where an interim analysis has just been published in Clinical Cancer Research, and I think this is something at least very encouraging, because we could see that also prospectively the disease stabilization could be confirmed in 50% of the patients. And just 2 weeks ago at the ASTRO, data from the Mayo Clinic has been presented, also confirming again that PFS6 was much higher than what is known from the benchmark, so 78% versus 26% if you compare to external benchmark. However, also here we have to say, this is only a single-arm study, and therefore this is not the evidence level that we need. What we need is a clinical trial where we have a randomization so that you can really compare the efficacy of lutetium dotatate in these patients against the local standard of care. And this is exactly what we're going to do in the LUMEN trial. LUMEN 1 is the first prospective randomized trial in neuro-oncology using a radioligand. It's being conducted by the EARCCS in 10 countries and 35 sites in Europe, and is evaluating lutetium dotatate every 4 weeks, 7.4 gigabecquerel in patients with recurrent meningioma, grade 1, 2, and 3, where no local therapy is indicated, no prior systemic therapy has been given, where we have measurable disease and a radiologically documented tumor progression of more than 25% in the last 2 years. And of course, the recurrent tumors need to be SSTR PET positive. Primary endpoint is going to be progression-free survival, and then we have lots of secondary endpoints and exploratory endpoints which are going to be of interest in order to better understand those efficacy relations and so on. Okay, but have we now really crossed the blood-brain barrier with a peptide? Well, I have to be very honest, we're talking about meningiomas, so brain tumors that are not really sitting in the brain, but outside of the brain, so they don't have any blood-brain barrier. So what is the situation if you're talking about real brain tumors in the brain parenchyma that have the issue of the blood-brain barrier, such as gliomas? Currently, there's also a study investigating lutetium dotatate in patients with glioblastoma, but the question is SSTR2 really good target for glioma patients? In publications like in this one, you will see a high contrast a high target to background contrast. But well, the background is extremely low because lutetium dotatate simply does not cross the blood-brain barrier, and you will see only uptake in the areas of contrast enhancement. And by the way, this is also the case for another small molecule. So also if you use PSMA ligands, you will see that you will find the uptake only in the areas with contrast enhancement. Okay, what do we do with this information now? Does that mean that molecules that do not cross the blood-brain barrier do not work in glioma patients? Well, I think we have to go a bit more into detail here. So just have a look at this patient where you see the contrast-enhancing glioblastoma. And I mean, in this part, you don't have any problems because the blood-brain barrier is broken. So your radioligand could just go in these areas. If, however, in the amino acid PET, you see that the very active tumor parts are exactly in the other spots, so where the blood-brain barrier is intact, then of course you will have a problem and you will have to think about methods on how to open the blood-brain barrier in these areas in order to get your radiopharmaceutical there, because otherwise you can imagine that these areas are going to progress, so it will not be effective in the entire patient. However, also very often we see patients like this one, where you have contrast enhancement which overlaps very nicely with the area of active tumor tissue. So if the entire tumor has a broken blood-brain barrier, then I think it's not the big issue, and then the chances are high that we could try our radioligand therapies, although they do not cross the blood-brain barrier in these patients. So I think patient selection is going to be essential in order to have a good treatment. And now we can even move forward. What about antibodies? Could we use antibodies in neuro-oncology? They are even much larger. And I think here a good proof of principle are the antibody-drug conjugates. You have heard earlier already that ADCs are having a big success in oncological treatments. However, in brain metastasis, the community was always very skeptical because they said, oh no, ADCs are going to be too large, they are not going to be effective in brain tumors. However, here a good example are the Tuxedo trials, which showed nicely that ADCs can be active in brain metastasis, and just recently at the ESMO, the Destiny trial has been presented, and also with very, very encouraging results. So ADCs, although antibodies are so large, can be effective in brain metastasis. And therefore, I think also for radioligands, although they are large, if the radionuclide is coupled to an antibody, that may be of interest also for patients with brain metastasis, for example, and they would be interested in HER2, and also in CA9, for example, because CA9 is highly overexpressed in glioblastomas and in brain metastasis as well. So I think that would be of interest in general. And also, I think there's much more to explore with regard to the type of the radionuclide you're choosing. So maybe actinium or other alpha emitters may be very helpful in very aggressive tumors such as brain tumors. We're discussing all these aspects of challenges, but also opportunities on how to effectively translate the theranostic concept to neuro-oncology in a recent publication in the Lancet Oncology. So you can read all our thoughts up there, and the take-home messages now are I think I could show you that we have a high clinical need for effective treatments in neuro-oncology, and I see an enormous potential of theranostics, but the BBB certainly represents a particular challenge, and I think amino acids, as they cross the blood-brain barrier, represent a very promising approach for glioma treatments. If peptides or antibodies are used, we should consider that the blood-brain barrier should be disrupted in the entire vital tumor, so please compare PET to MRI here, and if you see that large areas of the tumor have an intact blood-brain barrier, we have to think about options on how to open the blood-brain barrier, for example, via focused ultrasound. Also, it would be interesting to discuss about local injections, if that is more effective. Meningiomas are totally different because they are outside of the blood-brain barrier, and I think therefore the size does not really matter here. And my main message is really what we have to learn, particularly in the nuclear medicine community, is to switch from individual compassionate use programs to meaningful prospective clinical trials in order to evaluate which treatments are effective. And if now you also think, well, Stefano was right, prostate is quite boring and neuro-oncology is much more interesting, please join us for the NMN Symposium. It's a Nuclear Medicine Meets Neuro-Oncology Symposium, which we're going to have next year for the second time from the 9th of 10th of May in Vienna. And we're going to talk about diagnostic and therapeutic innovations in the era of precision medicine, and we'll be happy to see you there. Thanks a lot.